going to talk about prenatal care. We talked about preconception care, and then we move on to prenatal care, and there are a number of goals associated with this. Number one, we want a safe birth, a safe passage for this baby to come into, and a safe birth for mom. Number two, this is an opportunity for wellness teaching. So one of your nursing diagnoses might be that there's a knowledge deficit. So this is an opportunity for that. To promote self-care, to provide physical care, to monitor fetal development, and to establish a baseline for their present health so that we can be aware of any changes that may take place. And also to prepare the mother for parenthood, as well as the father or significant others that may be involved. There is a general schedule for prenatal visits. Generally, the mother will go once every 4 weeks until about 28 weeks along, of course, unless there's problems that need to be addressed. But the general accepted schedule is once every 4 weeks until about 28 weeks. And then we'll bump it up to every 2 to 3 weeks from about 29 to 36 weeks. And then from 36 weeks on or 37 weeks, we will go every week until birth so that things can be closely monitored. Obviously, this can be adjusted if complications develop. So what do we want to do during these prenatal visits? Well, number one, we want to take a history. You have to think about your history that you've already learned, and let's talk about some specific things that you want to pay attention to. An obstetric history. This might include what number of pregnancy is this? How far along are they? Have they had previous pregnancies? Have they had previous miscarriages? A menstrual history. Have they been regular, irregular? Have they been heavy? Have their periods been heavy? Have they been light? What has that been like? What kind of contraceptive may have already been in use? Or what kind of contraceptive may they consider later on, which would be addressed later, way on down the road. Any medical surgical history that might be pertinent, any surgeries, medical conditions that can affect this pregnancy. And a family history. Are there any birth defects that run into the family? One thing I like to ask is, if there are women involved in the family, how were their labors and deliveries? How were their pregnancies? And also consider the past medical history of a partner. Is there anything significant that we need to keep in the back of our minds that may affect this pregnancy? And don't forget psychosocial counterpart involved, because emotional and mental well-being can play a direct part on the progress and success of a pregnancy. Then we'll do the physical exam. Vital signs, including fetal heart rate. And one thing that you want to do is you want to ask about pre-pregnancy vital signs, because vital signs during a pregnancy can change. Their weight. Also ask them, have they gained or lost weight compared to what you're seeing? Nutritional status. You might want to do a diet history. A pelvic exam to look for, maybe do a pap smear, check the size of the uterus. Is there any bleeding? Are there those signs of pregnancy present that only a healthcare practitioner can see? And then to estimate the date of the birth, which will be covered in class. Labs, including a urinalysis. Their fundal height. Can you measure the fundus yet? One thing about fundal height is after about 20 weeks, the height of the fundus in centimeters actually corresponds to the number of weeks that a woman is pregnant. For example, when you measure from the fundus, the top of the uterus, to the symphysis pubis, if it measures 20 weeks or 20 centimeters, then likely that pregnancy is about 20 weeks along. If they're measuring much higher, Then it could be that we're looking at a multiple pregnancy, maybe too much amniotic fluid. If they're measuring significantly smaller, are we looking at a baby that's very small? Are we looking at a nutritional status? Are our dates off? So fundal height can become very important. And then we're going to review any discomforts and or complications that she might be having. Common lab tests that are generally done include the first trimester, a blood type and an RH with an antibody screen if it's indicated. Remember, your blood types are A, B, O, AB. You want to know the RH factor. Is it positive or negative? Because you might want to consider RhoGAM if it is negative. And these other ones, like when I say a CBC, I don't want you to concentrate on the 25, 30 different things that are included in a CBC. I want you to concentrate on your hematocrit, your hemoglobin, which indicates our blood levels, your white blood count, which can be indicative of infection, platelets. Platelets have to do with clotting. If a mom gets into trouble and those things are abnormal, then we might look at those other tests, but please get a good idea of what the normals are for those. We screen for syphilis, we screen for rubella, TB, hepatitis B, HIV, cancers, group B strep, group B beta hemolytic strep, which is can be carried, it can be transmitted to the baby. We really don't know what the source of that is, but we do know that it can be transmitted and make baby very, very sick. Gonorrhea, chlamydia, and we're going to do a urinalysis for protein, for glucose, for ketones, and any sign of infection like the presence of blood or white blood cells. Now, as you start learning about labs, you need to make the correlation as to what they indicate. Protein is not going to be normal, and when you begin to study complications, you'll see what that's about. Glucose, as you know, is the presence of sugar. What can happen in a woman is they become to where they hold on to a little bit more sugar in their system because, remember, they're growing a baby, so it's not uncommon to see a trace of glucose. Ketones can be indicative of burning of fat. So if you have a mom that's not eating or is hyperemesis, too much vomiting, they could be burning fat, and that will show up as the presence of ketones in the urine. Second trimester, we'll probably do an alpha fetal protein, which can be indicative of neurotube defects. Remember, we've already put her on folic acid to try to thwart any of those effects. Third trimester, nothing new. We're just going to repeat any of the above as indicated. This is a really good pictorial of changes during pregnancy. You can see that we have respiratory changes, metabolic changes, musculoskeletal, cardiovascular, urinary and renal, the uterus, endocrine, integumentary, vaginal changes, GI changes, changes in the breasts, and all of these changes happen to support a pregnancy and to support what the infant or the newborn needs to sustain after it gets here, as far as what it might require for the mom. Now, what you need to do is you need to pay attention to these changes and note that they will increase as the uterus begins to get bigger, as that baby begins to get bigger. So not all of this happens at the same time. You'll see more of this also in your reading, but this is a very, very good pictorial of changes that happen. One thing I want to touch on is what's called the physiologic anemia of pregnancy. Remember, we already said that you have to pay attention to the hematocrit and hemoglobin. Well, with anemia, you generally have a low hematocrit and hemoglobin. But in pregnancy, there's a couple of things that happen that just aggravate that situation. Number one, the plasma volume increases by 50%. That's the fluid part of the blood. Increases by 50%. Your red blood cell mass increases, and with that an increase in an iron demand, because we've got to have more oxygenation. So, let's say that I don't increase my number of red blood cells, but I increase my fluid that's moving around in there. Now, one thing you need to consider is a stick for blood. When you go in and stick somebody for blood, that is nothing more than a stick in time. It's not like we have this actual running tally that goes on. It tells us what the blood is all the time. It's just a stick in time. So let's take a look at this, and I want you to get the picture of this. Number one, if you look at this, this is a grading of anemias. This is what, theoretically, if this was a blood vessel, this square of blood vessel, if it was normal, maybe the red blood cells in there would look like this as far as their distribution. You start to add a little bit more plasma, which is what happens with the physiological anemia of pregnancy, and you're going to see that they have less, and then they can have less, and even less. So if we get down here in the serious, severe, life-threatening, and even the moderate, and we don't increase the number of red blood cells, our oxygenation goes down. So what do we need to give these ladies? Well, the first thing we need to give them is iron to jumpstart their bone marrow to help produce some more red blood cells. Because regardless of whether this is iron deficiency anemia, physiologic anemia, anemia from maybe bleeding or nutrition or whatever, anemia is anemia. But again, let me say that we see it in pregnancy because we have that increase in volume. So if I stick in here, if I take a needle and I stick it in here, then what that does for me is it gives me a normal hematocrit and hemoglobin of around 40-ish or so. If I have a stick in here, because I have that increased plasma, that's not going to read 40 anymore. That may read, 34 or 32 with a hematocrit. But regardless, it's still anemia, and we need to address it. It is not uncommon for pregnant women to walk around and to consistently see low hematocrits and hemoglobins in a woman who's pregnant. Now, just because you see that does not mean that it's normal and does not mean that it can't have adverse effects. So remember, we give them iron. Here's another picture down here in the lower corner. Normal amount of red blood cells, and then what an anemic amount might look like. So I just wanted you to see that. So as you're going through these, I want you to look at your NANDA list, and I want you to think of nursing diagnoses. And remember, you can always have a risk for nursing diagnoses. For example, one might be risk for alteration in oxygenation related to the presence of physiological anemia, or related to decreased number of red blood cells related, because of the anemia. However you'd like to word it. So be thinking about at least 5 nursing diagnoses, actual or risk for, that pertain to the material above.